Hello, everyone. My name is Anthony Ojukwu. We are pleased that you could all join us for this week's lecture in Volume 4 of our new Neuroanatomy Didactic Series, which brings you lectures from experts in the field covering different topics each week. This series was created by trainees and early career neuropsychologists, including standing members of the No Neuropsychology Board, as well as members of the No Neuropsychology Committee. Before we begin our lecture, one of the main goals of No Neuropsychology is to provide our audience with free, high-quality didactic content. Every No Neuropsychology and No Neuroanatomy lecture is available on our YouTube channel, so be sure to check it out, subscribe, and like our lectures to get first access to new content. Additionally, No Neuropsychology works to bring you learning and discussion questions that are provided with specific lecture content. You can access these on our website. Here are the disclaimers for the series. This training is not meant to replace formal education in neuropsychology, and the speaker's views are their own. Questions can be submitted via the Q&A box located on the lower left side of your screen, and the recording of today's lecture will be made available on our website and YouTube channel later this week. Now, it is my pleasure to introduce Dr. Rachel Tangen for today's lecture titled Neurodevelopment and Fetal Alcohol Spectrum Disorder. Dr. Rachel Tangen, PhD, ABPP, is a board-certified pediatric neuropsychologist at Rainbow Babies and Children's Hospital in Cleveland, Ohio, and an associate professor of pediatrics at Case Western Reserve University. She completed her doctorate in clinical psychology at the University of Houston and the fellowship in pediatric neuropsychology at Children's Hospital, New Orleans. She is co-director of the RISE Developmental Behavioral Pediatric Fetal Alcohol Spectrum Disorder and Substance Exposure Program at Rainbow Babies and Children's Hospital. She has a specialization in assessing cognitive and neuropsychological effects of prenatal alcohol and drug exposure in children, and she has been involved in training and educating medical professionals and community members regarding the identification and treatment of fecal alcohol spectrum disorder. And with that, please help me welcome Dr. Tangen.
Hi, thank you so much for the invitation to come and talk and also for that introduction. I'm going to try to share my slides. Says someone else is sharing. Can I still share? Here we go. Yeah. All right. All right. As the introduction said, I'm Rachel Tangen. I am a pediatric neuropsychologist here at Rainbow Babies and Children's Hospital. And just to start real briefly, talking about how I got involved with fetal alcohol spectrum disorders. I really didn't have a lot of experience with fetal alcohol spectrum disorders or drug exposures during my training. I came to Rainbow Babies and Children's and was doing kind of typical clinics. And I'm in a division with developmental pediatricians. And one of the developmental pediatricians had been seeing a lot of internationally adopted children and was interested in fetal alcohol exposure and starting a fetal alcohol spectrum disorders clinic. So I had done a lot of my training and research with ADHD and executive functions, and I thought it might be an interesting population for that, for those interests, which it is, which we'll talk about. But so I said, sure. And, we started this clinic about 15 years ago. So my co-director, Dr. Denise Boda, sort of pulled me into this population with her. And I've been working together since. And it's been one of the nice things to have a medical team or a medical interdisciplinary clinic so that you're not just in isolation in doing these evaluations. So let me talk about fetal alcohol spectrum disorders and neurodevelopment and neuropsychological outcomes in this population. There we go. I don't have any conflicts of interest or disclosures to make. What I do want to talk about and what I want hopefully for you to get out of this talk is to be able to describe how prenatal alcohol exposure affects physical and neurological development, starting with the fetus, and then identifying areas of the brain that are affected by prenatal alcohol exposure. Be able to list those four main diagnostic criteria for FASDs, identify cognitive and behavioral domains that are affected by prenatal alcohol exposure, and then hopefully a few minutes at the end, just recognize interventions that can be helpful for FASD. So where to start? What is FASD, first of all? And when we use that term, it's really an umbrella term. It's not a diagnostic term. Here in the United States, anyway, it's not a diagnostic term. So it's really a term that describes the range of effects that can occur in anybody whose mother drank during pregnancy. So having prenatal alcohol exposure, and can include physical, mental, behavioral, learning disabilities, all those types of issues with possible lifelong implications. And you may have seen some of these different diagnostic terms: fetal alcohol syndrome, partial fetal alcohol syndrome, alcohol-related neurodevelopmental disorder, and some diagnostic criteria use different names under that, or different names for that. There's also alcohol-related birth defects, and in the DSM, where what it falls under is neurobehavioral disorder associated with prenatal alcohol exposure. So we're going to get more into that, but just know that when I'm talking about FASDs, it kind of encompasses those different diagnoses, but they're all under this umbrella. So what is the prevalence of FASD? When we think about that, it's the studies have been done more recently show an increased rate than what we used to think. Because really longer ago, we were looking more purely at FAS, so just fetal alcohol syndrome, kids who had all symptoms. And that group is a much smaller group than when we look at the whole spectrum. So, this picture shows, we're just touching the tip of the iceberg if we're just looking at FAS as a diagnosis. But if we're including partial FAS or alcohol-related neurodevelopmental disorders, you get a much higher prevalence. And the most recent study that was done in 2018 shows like 1 to 5% of US school-age children have a fetal alcohol spectrum disorder. Some populations that are higher risk, if you're working with some of these other groups, you might see a higher rate. So kids in foster care or have been adopted, as I was talking about with my medical partner, international orphanages, Native people in the US as well as in other countries, psychiatric kids who have in psychiatric hospitals or in correctional facilities, you'll see higher rates. So it's generally thought that FAC is under-recognized and under-diagnosed. So why is knowing about FASD even important? We're looking at symptoms of prenatal alcohol exposure, but why is knowing about FASD important? So first of all, it's just the most common known cause of neurodevelopmental disorders and intellectual disabilities. And the big thing is, it's preventable. It's something that, based on behavior, it can be prevented. So these are the newest data, and it's something that I actually just changed in this presentation because, as you can see, previously it was 1 in 10, 1 in 9 women who are pregnant, have reported drinking, and it's down to about between 1 in 7, 1 in 8 in this newest data from 2018 to 2020, which is the newest data that's out there from the CDC. And so it's a high percentage of that, any drinking during pregnancy. And then binge drinking, which is about 5% during pregnancy. So you still get a percentage of women, who are drinking even when pregnant. Half of women just in general drink, but there's, half of pregnancies are unplanned. So sometimes there's alcohol exposed pregnancy before even women know they're pregnant. And we also want to know, just because early intervention results in better outcomes. So we want to know early on if this is something that's going on so that we can help kids from a young age. All right. So what do we know about alcohol and how it affects the fetus? So we do know that when mother drinks, alcohol crosses the placenta freely, and the amniotic fluid that the fetus is in acts as a reservoir for alcohol. So it sits there, and the fetus will have a higher blood alcohol content and has longer exposure to the alcohol than even the mother has, because they can't get it out of their system as fast. They don't have the alcohol dehydrogenase that the adult has, and so they're sort of in the alcohol for a longer period of time, so higher blood alcohol content for a longer period of time. You can see, greater risk to the fetus when there's heavy drinking, which for women would be 8+ drinks per week, which is what the CDC indicates as heavy drinking, and then binge drinking, which is 4+ drinks per episode. So those are the current criteria for that. But it's not just purely like how much you drink. Sometimes some other things that have been looked at are timing of within the pregnancy, again, the dose, and then the pattern, is it binge drinking, heavy drinking, what level of drinking, and the pattern of it that is looked at. So if we think about, when the timing is within in a pregnancy, we can think about, where along development the fetus can be impacted, and if it impact what physically and what neurologically. So if we think about really early on, if the mother is drinking and maybe she doesn't even know she's pregnant, we can see different body systems that are impacted. Heart is definitely one, limbs, definitely things on the face. So cleft lip can be seen, things that are related to palate, cleft lip, cleft palate, the facial features in general, ears can also be something that are impacted. So that early developmental period in those first weeks can definitely be something where you will see alcohol impact organ systems as well as development of features. I'm going to talk about that in just a second. So you can see birth defects, and these are the 5 main things that get talked about. So heart defects, kidney, issues with eyes and vision, hearing, and development of ears and hearing, as well as the skeletal system. You can see issues with any of those kind of organs and organ systems. So, going more to what we look at as neuropsychologists and thinking about, well, how does this impact the brain and neurological development? So there are a lot of ways it can. So I'm not going to go into great detail about every single way, but I'll kind of make some generalizations. So one of the big ones is alter neurogenesis and migration of neurons. Also a big one, increased neuronal cell death, and apoptosis can alter the dendritic growth, alter neurotransmitter receptors, and a kind of a longer list of things. So the big things are, it can lead to neuronal cell death. You're killing cells or creating a programmed cell death with like apoptosis, but also not just fewer cells and cell death, but altering migration of neurons and where they're going. And once they get there, the dendritic growth that is supposed to be going on. So all those things can be impacted by alcohol to the developing nervous system. When we look at that more specifically by time frame, we can break it down by thinking about, so first trimester of pregnancy, what's happening in our brain or in our nervous system, and how's that developing. So, we're thinking about neurons developing and multiplying. If you're having alcohol exposure and you're killing off those neurons, you are going to have fewer neurons. So, right, smaller brain, less, a smaller brain to make those connections. So, a lot of times you will get lower cognitive function in general with just the smaller brain just right from the beginning. So we're not multiplying, and then we're not migrating to be. So in that end of first trimester, beginning second trimester, different parts of the brain are developing. So you're developing the hippocampus and the cerebellum and the thalamus, and different parts of the brain that where neurons are supposed to go, and the cortex where the neurons are supposed to go and migrate to specific places and then branch and make those connections. And that is not happening as well. Things are not migrating to where they're supposed to be, or not making the connections they're supposed to be. So impacting in the second trimester, where you get, again, disruptions in cognitive functioning and learning and memory, executive skills. So all those things that, specific brain regions are supposed to be doing. Then you move into third trimester, and again, you get quite a bit of growth of the brain rate. In the third trimester, you get a lot, things are not necessarily first developing, but your brain is growing bigger, and you get a lot of that white matter myelination developing. And so if you're drinking during that period, you're having issues with the myelination. So difficulties with timing, then we see neuropsychologically, lack of coordination, again, disruptions sometimes in memory, executive skills, those sorts of things, where and speed, where things are not going as quickly. So you can see it across all trimesters. You might not get low IQ across all, if you're just drinking at certain points across all trimesters, but you are going to see specific effects. All right. So one of the biggest things that you can see from a neurological perspective are, just again, size of the brain. So microcephaly or smaller brains that you can see. And this is a extreme example where this is a young brain of I think 6-week-old who died of different not neurological causes, and this is autopsy. And then alcohol exposed, very severely alcohol exposed brain, and you can see the size difference. You can see the difference in the development of the gyri sulci, right? And so things are not developing the way that they should be. But one of the big things that they've looked at is size. But you can also see other neurological issues like seizures, or kids that are diagnosed with cerebral palsy, and a lot of, what I'm going to talk about next is, abnormal brain imaging that can be seen. All right. This diagram, I just will say, was made by Sarah Madsen, who is a really great researcher in the area of FASD. She and her colleagues have written, I think, multiple chapters. If you guys don't have, if your pediatric neuropsychologists are interested in pediatric neuropsychology and you haven't read the book Pediatric Neuropsychology, I think it's called Theory and Research. It's in its third edition and has a wonderful chapter about FASD and talks about all these brain areas. So I would highly recommend it. But this just goes over, if we're talking about what I have said so far, that, cells, okay, neuronal cells are impacted, neural cells die, they don't go where they're supposed to, and it impacts different areas of the brain. We're talking about a lot of different areas, right? It's not just one area or maybe just a specific area, but a lot of different areas of the brain that can be impacted. And so in this chapter that was written and in this diagram, it just talks about, you can see things cortically, you can see with the hippocampus, the basal ganglia, the cerebellum, the cortex, as I said, things in the thalamus and the diencephalon, as well as the hypothalamus. So you're talking about multiple areas of the brain that can be impacted and that can show up on imaging. The three biggest ones probably are the corpus callosum, and the basal ganglia. Uh, is that those two for sure, and then the cerebellum get indicated most often, but also other areas in research have also been areas that have had deficits. Um, so one of the biggest things that's looked at is brain volume. So how big is this area of the brain? So in the cortex, this is a study here that shows some graphs by Susan Astley, who's also done a lot of research in the area of FASD, but shows more severe FAS or partial FAS. You're going to have lower, smaller frontal lobe volumes, and it gets bigger by diagnosis. So you would expect less alcohol exposure, and you have bigger frontal lobe volumes and less severe FASD, and then the controls. So two areas of the cortex that are often implicated are frontal lobe and parietal lobe. You have basal ganglia, as I said, the caudate definitely, as well as putamen. And then the pallidum too, and some of the recent research also comes up. Hippocampi, cerebellum, and so not just size necessary with cerebellum, but also you can see hypoplastic cerebellum, sometimes malformation or displaced cerebellum in kids with FASD. So that's what some of the research also shows. And then the corpus callosum definitely you can see agenesis, hypoplasia, thinning, displacement as well, or disproportionate kind of regional reductions in the corpus callosum. I think I have next, yeah, just some examples of that. So A is, if you can see, here's like where the corpus callosum should be, right? Like that's an agenesis completely. And then B is sort of hypogenesis, it's not complete. And some of the research, really looks at the corpus callosum as being one of the major areas that is impacted. So all of these are kind of normal variations, C on the side here, whereas A and B are two kids with FASDs that show issues with the corpus callosum. And this is just another study too that kind of looks at the A is our child without an FASD. B is a partial FASD, and then these bottom two both have FAS. So little less severe. Their corpus callosum don't look as bad in this one. Some of the down here, I think, show a little bit more. If we can see some cerebellar issues in C and D, kind of how that development is. So you definitely there's research in imaging that supports that there's reduction in size in some of these areas, as well as some of the formation of these different brain areas. All right. So, as some of those graphs I was showing you show, like, okay, greater alcohol use equals, greater brain imaging issues and likely greater neurodevelopmental effects. But that is something that is not always true. We don't always see a one-to-one correspondence of you drink this much alcohol and you have this much effect. And so some of the research in that is why does that happen? And it's not completely known, but there are some genetic factors that are being looked at, both with the mother as well as with the fetus, with the child, about what can be protective. Even with a mother, it drinks. So why do some kids not develop as many symptoms? And there is some research that there are some genetic, factors that are protective, and it's not completely known yet what those all are. But that is why sometimes, you might drink and you might not have a child who has a fetal alcohol syndrome, and somebody else who might drink the same amount, you would have an FASD. And so what the general consensus is there's no safe amount of alcohol during pregnancy. So even though we talk about high amounts of alcohol causing FASD, we don't really know like what the lower level of that. There's no safe amount, and the public health message really is do not drink alcohol when pregnant, because we don't know. We don't know if you could be somebody who has a lower level of tolerance for that, and your child also has a lower level of tolerance for that. So you might be somebody who would develop an FASD, whereas somebody else might not. So public health message is don't drink alcohol when pregnant. All right, so that is kind of the background, the neurological, the cellular aspects, the neuron aspects of fetal alcohol exposure. So I'm going to talk a little bit about just diagnosing fetal alcohol spectrum disorders, which sometimes I think for psychologists, neuropsychologists can be confusing with some things, and also, can I do this? Should I do this? Questions that come up. So there are a lot of different diagnostic guidelines out there. In the US, there is an FAS, just an FAS guideline through the CDC. So that's just the fetal alcohol syndrome. It doesn't really go into FASDs. DSM criteria, which I'm going to talk a little more about. There is a criteria through the University of Washington called the 4-digit diagnostic code. Susan Ansley developed this, which I mentioned her name before. I have some pictures that she kindly shared and allowed me to show you all of some of the features of FASD, but she's done a lot of research in this area. And then there's the NIAAA guidelines that you often hear about, OIMI 2016, and a lot of people use those guidelines as well. There are guidelines in Canada and Australia that are also slightly different, which you may have heard of. So people have sort of their own. The big take-home message, though, is there's really across all guidelines 4 major things that you're looking for if you're looking for an FASD. So the first one is, what do you know about prenatal alcohol exposure? Do you know whether the mother drank alcohol or not during the pregnancy? And if you can get any information about, how much or how frequently, that is good. Sometimes you don't know those. Sometimes that's hard information to get. The second one is growth, both with height and weight, looking at if there's growth retardation. There's facial dysmorphology or facial features that we specifically look for. And here are some of the examples of pictures that I'm going to talk specifically about those facial features. And then, how significant or is there central nervous system damage that we can look at in several different ways. The big thing is that, a lot of people think that you have to have these facial features. If you don't have the facial features, then it's not and FAST. But really, the physical characteristics are only seen in about 20% of kids. And when we were going through, that early timeline of what can be impacted, when we think about some of the development of the face and the eyes, that really happens in, 1 week in early development. So around my developmental pediatrician colleague usually says around 8 to 9 weeks of development, you're going to get a couple days where you're developing those facial features. And if mom wasn't drinking heavily or drinking at all during that time period, you might not see those facial features. But what are they? What are the facial features that we are even looking for? So the three things that are actual criteria for fetal alcohol syndrome are eye size. So that's that palpebral fissure length. So you're taking a measurement from, one side of the eye basically to the other. So how big are the eyes? Philtrum. So your philtrum is that area below your nose, above your lip. And you're wanting to, see a nice groove in that area, not flat. And then the upper lip, how thin is the upper lip. So if you have a very thin upper lip, a smooth philtrum, and small eyes, those are the things that are being looked at for facial features. In our clinic, we use a photograph and a computer system to analyze that. You can also, and the things they train the pediatrician to do are, you can also use a ruler to kind of measure that and see where things are at. Because you do convert those to Z-scores. There are standards for those palpebral fissure lengths, and you're wanting, in the system we use anyways, 2 standard deviations below what you would expect. So that gets looked at. And then how do you judge a philtrum and upper lip, right? So you're looking at this, and there are comparison cards out there. These are from the 4-digit code, which is the system we use in our clinic. And there's, ranking basically from 1 to 5, with 1 being completely typical, and then 5 being, 4 to 5 being areas where you're like, okay, this is not below expectations for these facial features. So those 4 and 5s are supportive of an FASD diagnosis. On the software too, you can do more where you're kind of like, what is the size of that? You can get kind of more subtle look, and not just kind of an eyeball look at like, is this a feature or not? So some of the software out there can look at things more, so you can have a more subtle look at it. So those are the three facial features: eye size, smooth philtrum, thin upper lip. There's also growth, as I was talking about. So height, weight, not the BMI. And you looking, when I'm in my interdisciplinary clinic, looking at all available growth charts. So if we can get early records, my MD colleague will look at anything from birth on up to see what was the lowest height and the corresponding weight to go with that. So is there smaller size? And weight or height below 10th percentile can be supportive of an FASD diagnosis. So growth is that other piece. And then evidence of brain dysfunction. So that can be in a couple different ways. So there can be structural. Is there any evidence of structural issues? Is there microcephaly? So small head. Is there agenesis of the corpus callosum? We have some sort of imaging already that would show there's some sort of structural issue. Do they have some sort of neurological issues? So like seizures, or some kids I've seen have had a shunt, have had hydrocephalus. And then the functional part, which is where my testing or neuropsych testing a lot of times comes in. where you're looking at developmental, cognitive, social, behavioral, learning scores. And those, depending on your system, can be 1.5 to 2 standard deviations below the mean. And in the system we use, the four-digit code, it has to be in 3 domains. So some systems are less strict about the number of domains. We look for it across 3 domains in the 4-digit code. So all systems will have, we need evidence of brain dysfunction, just like how severe and how many domains can vary depending on what system you're looking at. So this is just how we work in our clinic with the 4-digit code. There's these different areas: growth, facial features, the central nervous system, and what we know about alcohol. This is just an example where we had a kid who didn't have growth and didn't really had like 1 facial feature, didn't have severe neurological, neuropsychological issues, but did have alcohol exposure. So they were on the really mild end of a fetal alcohol spectrum disorder. And this chart just sort of goes over that, where if we look at it, there is these requirements for some of the diagnoses for facial dysmorphology, for growth deficiencies, but really, for FAS, you need all those things. You don't have to have this, only one where you don't have to have confirmed alcohol exposure, because if you have the facial features and you have the growth deficiency and you have the central nervous system impairments, then you have you have FAS, whether or not there's a confirmed or not alcohol exposure, because nothing else genetic, nothing else would produce those same symptoms. So that's the only one where you don't need to know for sure whether there was alcohol or not. All the other diagnoses in systems, you really need to confirm, do you know if the mother drank or not? Do you have evidence, support? And it doesn't have to be necessarily the mother saying that, but sometimes you have records through the county, you have somebody else who was present during the pregnancy, and you can get information from other sources. So you need confirmed alcohol exposure, and you need evidence of central nervous system impairment. Those are the 2 main things in actually across systems to be somewhere on the fetal alcohol spectrum. You have to have a confirmed prenatal alcohol exposure, and you have to have significant central nervous system impairment, significant, neuropsychological, neurobehavioral impairment. The facial features and the growth issues, for some diagnoses, you need them, but to be somewhere on the spectrum, you do not necessarily need them. So a lot of systems sort of have gone away from some of those features and said, we can classify kids on the spectrum even if we don't have those physical findings. But there are other risk factors for kids, and we do think about those things as well. So whether genetic factors there are for the mother and the child, if there was other drug use during pregnancy, is something you want to think about. And these are risk factors of like who develops and who doesn't. Increased maternal age during pregnancy, lower maternal body weight, poor nutrition, lower maternal education, rural residency, and lower SES. And the rural residency is one that I was thinking about while putting together some of the slides for this talk, because some of what I was reading is that sometimes the rural medical system, you can't get the same level of early care, or it's harder to get, consistent care. And so just thinking about that might be why you have a rural residency risk factor. All right. Going on. All right. So what sort of neuropsych deficits do we look for in kids with fetal alcohol spectrum disorders? So this is my part of the clinic usually, where I'm looking at what are the deficits that I'm looking for, and who would be classified as having an FASD. So first of all, when we test kids, it's not just specific areas. As we've talked about, there's a lot of different areas that can be impacted by prenatal alcohol exposure. So it is a pretty comprehensive neuropsych evaluation usually. In the 4-digit code, they talk about, 10 areas that you can look at. 3 of those should be 2 standard deviations below the mean. There has been a lot of research and things looking at a specific neurocognitive or neurobehavioral profile. I haven't seen where there is firmly a neurocognitive or neurobehavioral profile with kids that I see. And even in the research, there's some suggestion, but not clearly, especially neurocognitively. There's not necessarily like, oh, it's all visual spatial issues, or it's all language issues, or it's all memory issues. The biggest things, if we're thinking about it, would usually be more a neurobehavioral profile. So things that are related to attention and executive functioning skills, impulse control, self-regulation, and adaptive skills are a lot of times the biggest things where kids are having problems. So that brings up the criteria that's in the DSM. I would say in my experience, I will use the DSM if I'm not in my interdisciplinary clinic with my developmental pediatrician partner. I will use the DSM because I'm not necessarily going to start looking for all the physical features, measuring things myself, or doing heights and weights are not always feasible in psychology office. So this in the DSM criteria, you do not need that. You can just use the neurocognitive. And so the big things are a symptom of neurocognitive. You have to know if there's alcohol or not, more than minimal. Neurocognitive, self-regulation, and 2 adaptive function system or symptoms are required. When we're looking at cognitive skills, here. We do think about intelligence, and as I was talking about, early brain development, you can see those smaller brains and issues with brain development that can cause lower IQ. And that is true more so with kids who have full FAS, have lower IQs, but still only about, quarter will really meet criteria for intellectual disability. And then if you have some of the other FASDs, the IQ means are higher, even up into the average range, and only about, 9 to 10% will have an intellectual disability. Some of the biggest things are, as I said, attention, hyperactivity. So, parents come in a lot. It's a very distractible kid, overactive, on testing, difficulty sustaining, shifting, difficulty completing tasks. I sometimes get a really slow processing speed, like on the WISC, or working memory issues, and difficulty thinking flexibly. And self-regulation and executive dysfunction are also big things. So impulse control. That is probably one of the biggest things parents have an issue with, like they just are doing things when they aren't thinking, and they don't think about their consequences of what's going to happen. They don't understand like a cause and then the effect of that, even if they've already experienced something with it. So that's one of the biggest things where parents are like, they did that, they should have learned something from it, and they didn't. Like that cause and effect is not there. Trouble, then with transitions, organizing, and sometimes just behavioral, emotional dysregulation comes up a lot. You also can see some memory impairments. In my clinic, probably it's some kids will have more severe, some more mild, but you can see it across verbal and visual domains. It's an area that hasn't been studied, I guess, as extensively as some of the others. if you think about the brain areas that we've been talking about, cerebellum, basal ganglia, you think about visual motor and motor skills, you think that that could be impacted, right? So you do see difficulty a lot of times with visual motor, sort of coordination and integration, dexterity sometimes, and in the gross motor, the balance, and a real clumsy kid. You also can see issues with language and communication, so speech and expressive language. You will sometimes, especially with younger kids as they're developing, sometimes that is a major issue. Sometimes with receptive language and kids just vocabulary, not understanding things. One of the biggest things I've seen is just this social communication. So difficulty with, pragmatic language with other kids, with non-literal language, understanding inference and things that are not just concrete laid out for you. That seems to be an area that is particularly sensitive. And then academically, you don't see as much pure like dyslexia, like the reading decoding and sight word issues, more on the side of reading comprehension. And that could be for multiple reasons, but some could be executive function issues or memory issues, language issues. Well, you're trying to read, you can read the words, but you're not processing, it in the same way. So the comprehension is poor. Math across the multiple areas can be a deficit, and that's probably the most common. Learning disability is a math disability. Again, spelling, like word reading, is often intact, but you have problems with writing and handwriting, and when you're putting things together when you're writing. This is just kind of skip over this quickly. This is just data that we had that we're trying to get a study, but higher rates of math disability than reading disability. Issues with a psychiatric diagnoses. The biggest one is ADHD. So 50 to 90% of kids with FASD will have an ADHD diagnosis. And that is definitely true in our clinic. We are closer to the 90%. But you also can see depression and anxiety and oppositional defiance is higher, conduct disorder and trauma-related diagnoses. A lot of those are in the 10 to 20% range, with oppositional being sometimes in some samples 30%. And adaptive skills, which I said was one of the other bigger areas. So, difficulty if you're giving something like a Vineland, you'll see issues with daily living skills and those social skills, the communication kind of across all those areas. It's lower, and this is an older study by Streisguth, but she had looked at, it was interesting, like IQ scores were slightly lower than average. So in her group, she was like 85 was the score for IQ. And then if you looked at math, the average score was like 75. So we're having some issues with math. And then the adaptive scores were 65. So even if you have an IQ of 85, your adaptive scores were 65. So it was like a major incongruency of your adaptive skills are not as good as your IQ would predict. And that's just, I go into more. One of the biggest things that we're trying to look at right now is just some of the social skills, and just kids having a lot of difficulty with their social interactions, and especially as they get into teenage years, having a lot of difficulty with being easily manipulated and immature in their social interactions, and then getting into trouble with legal systems and school systems and all kinds of things because they're not understanding and having poor social interactions. There's a lot of complexity in cases though too, and so you always taking that into account, that you can have a lot of other psychiatric issues and family history of psychiatric issues that might be playing a role. There might have been abuse or neglect, especially with those kids that we see from foster adoptive care. And you might not be able to get a good history, and you do want to make sure you rule out, other genetic disorders that might be the actual reason that the child is having these issues. All right, I think I don't I should probably leave some time for questions. I'm just going to say outcomes are not great in the early research, but what we do know that early diagnosis is helpful, stable and rich environments where there's not violence, and where you're not living with substance abusing individuals, having your basic needs met, and having more individual attention in the home. There are programs out there that are specific to dealing with symptoms of FASD, including the psychological symptoms, the academic symptoms. And so there are things out here. When I started this clinic, there wasn't a lot out there, and there's becoming more and more. And one of the things I've been working on in my program with my colleagues is this Family Foundation's BEST program, where we do try to give parent support and training basically in how to work with kids. And so here is my thank you to my clinic team, Dr. Boda, who, as I've mentioned, who's the developmental pediatrician, and also Kim Burkhardt, who's a psychologist who works with me. And then I work on another team, and just a shout out to my extended Rise Peds team, where I see young kids. They start working with moms while they're pregnant and drug addicted. And so we have a Rise Moms program, a Rise Peds program, and then I see kids at 1 or 2 years old and try to get them in early. So thank you to all my teams. All right. Try to hurry up there at the end. I am done. So any questions that you guys have?
Indeed. Thank you so much, Dr. Tangen. That was a phenomenal presentation. Thank you. I definitely learned a lot, particularly about FASD and so many misconceptions that we do have in the community. So thank you so much for that. And yes, we do have some questions. So a participant wanted to ask that they are interested to know how, as clinicians, you deal with the cultural patient explanatory models of fetal alcohol syndrome. So, for example, in South Africa, alcohol forms part of key cultural practices, even when introducing pregnancy and or the birth or arrival of a child to the ancestors. As such, it is difficult to avoid exposure. So traditional beer, for example, is often used in these practices, but also believed to be nutritional for the pregnancy. And when this kid presents with cognitive challenges in absence or evident morphological changes, cultural explanations linked to ancestry is often attributed. And difficulties in learning are often explained as disconnect with ancestors and rituals to be performed. And this creates difficulty for interventions, but also redirection in special education support systems. So, as a clinician, as an expert in this field, how do you deal with the cultural explanatory models of fetal alcohol syndrome?
Yeah, that is a good question, and that that's very interesting that in that culture that is kind of how things are explained. But there are different cultural across the globe. This is a an issue, and you see rates in some cultures higher than in others, depending on what the amount of drinking of is in that culture. So, I mean, obviously, you want to be sensitive to people's cultures and their cultural beliefs and understandings, but also, trying to be, I guess, clear about what is known from a medical perspective about, brain development, and definitely in the U.S., there's a lot of the geared toward, you are impacting, your child's development if you are drinking. So I think is something that sometimes it's hard to address the whole culture right at once. But I think within a country, if it's something that is an issue, a lot of times there is more push. So even in the U.S., right, there's still quite a bit of a drinking culture where there's trying to be this education about it. And so I think in every culture, every society, it is as I was saying earlier, tough, because it's not every kid who, right, where you drink, they're going to have severe issues. Right. And so sometimes that's a disconnect. And in the literature about how do we get moms to stop drinking while pregnant, that's one of the things that comes up is like, how do you address And there's people who do that just in all of their research is like, how do we educate people about, FAS and how this is an issue, but that there's might be a disconnect based on, what professionals are saying them to, but also, what is in the, culture is saying to them. So I would say as, what I would say, usually I don't see kids until, after, but, it is to try to make this point that, there can be lots of factors that impact, but what we know is the brain is that can definitely be impacted by alcohol, and just be consistent with that point with families.
Yeah, that was a very good one. Thank you so much. And I definitely think we need more conversations on that. So another question is, are there certain brain structures and or pathways that are involved in understanding cause and effects and understanding consequences that make sense with FASD presentation?
Yeah, I mean, so what we think about with cause and effect is generally, those executive sorts of skills, right? So we're thinking about this happens, and then this is kind of, related to that, right? We're learning from something. And so when I think about it anyway, I do think about frontal lobes, right? And executive skills. If we think about kind of other areas though too that also have some, maybe some executive component to it, if we do think about there's aspects of basal ganglia, and we think about flexibility, flexible thinking or switching our thinking. We think about even the cerebellum. There's research about, that there's some a role of the cerebellum, and some it can be some attention and executive skills as well. So the things that we know can be impacted by alcohol, we can see that with the cause and effect and the executive skill deficits.
Okay, thank you so much for that. And we have one more question, if that's okay. So, given the variability of neuropsychological profile, would you consider a battery of neuropsychological tests or a deficit-specific test-based approach based on the presenting complaints?
Oh, so the question is like, would you do a more broad-based, or would you do
Mm-hmm,
a deficit specific?
mm-hmm,
Okay.
mm-hmm.
Yeah, I mean, I do, and so obviously I'm in a clinic where we're trying to look for FAS. And so if that's the question, I'm going to do a broad-based neuropsych evaluation, because I want to hit all those domains and see, if there is issues in kind of multiple areas. If I wasn't doing that, if I wasn't looking for FAS, I might be doing more of a deficit based. But if I'm looking for, is this FAS, I would do a more broad based
Oh, yeah.
psych eval.
That's very interesting. And I think doing the broad base also helps you to, identify things that don't exactly come to mind during the
Yeah.
presenting complaint. So I think that's good. So another is, what might you expect for young adults with mild FASD as they age? So let us say someone is coming in for a neuropsych evaluation in their 20s after they missed their early intervention window. So
Mhm.
what types of intervention would you focus on, or what are the ways to set expectations for problems that may be anticipated?
Yeah, so that's a good question. I think that is where the field sort of is right now, looking at it with a lot with transition, and kids going from adolescence to adulthood. And there are a lot of kids who I would say, even when if I saw them when they were younger and they were like, I'm like, okay, their IQ's, low average. They're doing pretty good on a lot of these cognitive measures. Their memory looks okay. Their language skills and their motor skills don't look too bad, but they have some attention issues. They have some executive function issues. And I see them at school age, and I think, okay, maybe that, they're going to do okay with some of these things. But then, we see them in teenage years, and a lot of times we do see a lot of issues with kind of how this executive function plays out with the adaptive functioning. And even if they have average intellectual, their IQs look good, they're having trouble with that decision making, and getting into a lot of issues with, say, I've had kids, get into a stolen car with a friend, pornography at school, like a lot of trouble, like just making good rational decisions. And so a lot of times, even with IQs that are average, you can see problems, right? So when you would typically say mild, right? They're not having severe cognitive developmental issues, but mild issues, but can cause real adaptive functioning issues. So where the field is. So I work a lot with the Society of Developmental and Behavioral Pediatrics, and we just kind of worked on a toolkit for adolescent to adult transition for people who are kind of right in that issue. So what should we be doing for kids who are trying to up in that range? So there are still things to be done, right? It's not going to be that early intervention, speech therapy, physical therapy, occupational therapy, but what kind of supports what does a young adult need when they're trying to transition into adulthood? And so a lot of it is based on a lot of structure and who's your support team and knowing what kind of areas, like we might need a lot of help with really learning adaptive skills. It's not something that comes naturally. We have to really teach those daily living skills. We have to really teach social interaction skills better. We have to teach how we want to communicate. So really being explicit about teaching certain skills, even at that level, even if a kid who's got average intellectual skills, how do we teach, functional skills in daily life and adaptive skills? So there's definitely things out there where people are working on those transition and how to help parents and the young adult or, adolescent to young adult, learn those skills as they're getting to an age where they're supposed to be more independent.
Thank you so much for that, Dr. Tangent. That was really comprehensive and very, amazing. Thank you for this presentation. It was really interesting. I learned a lot, and I'm certain that a lot of us also did the same. So thank you to all for joining us today. The recordings of today's lecture will be uploaded on our website and on our YouTube channel by the end of the week. And if you're interested in attending more of our lectures, we would love to have you next week, where we'll be having a lecture on vasculature and stroke. To have a lovely day ahead, everyone. Bye.